This is postoperative complications following internal fixation of periprosthetic tibia fractures with plating, nailing, or revision total knee arthroplasty. So periprosthetic tibia fractures are fractures in the presence of a non-native joint, such as a total knee replacement as shown here, or less commonly an ankle replacement. And these are complex injuries that are likely to increase as total knee replacement becomes more common in the general population. And in general, these fractures do poorly in the postoperative period. So a study at Mayo Clinic in 1997 found subsequent periprosthetic tibia fractures in 0.4% of cases, but this effect is likely to be more significant today as total knee replacements are becoming more common. This study also resulted in the Felix classification system shown here. So Felix type 1 fractures are of the tibia plateau. Felix type 2 fractures are adjacent to the tibial component of the knee replacement. Felix type 3 fractures are distal to the tibial component, and Felix type 4 fractures are of the tibial tubercle. And these fractures are relatively poorly described in literature. Their counterpart, the periprosthetic femur fracture, is much more established, and a purposeful effort towards evidence contribution is still needed for tibias. So the study's objectives are to describe periprosthetic tibia fractures in the cohort with the related demographic data, as well as how methods of internal fixation impact post-op complications. So this is a retrospective cohort study at a single level 1 trauma center from 2013 to 2022. And demographic data, comorbidities, and fracture characteristics, injury characteristics, and operative characteristics were all collected. And some demographic data included age, gender, race, BMI, and some comorbidities that were described were chronic kidney disease, heart disease, lung disease, and cancer. And some fracture characteristics included Felix classification, like it was just shown previously, whether there was loosening of any of the total knee implants. And injury characteristics included time to presentation from the injury, the mechanism of injury, whether it was a high versus a low energy mechanism, and operative characteristics included estimated blood loss, transfusions, whether it was a staged versus a non-staged procedure. And these fractures were separated based off definitive fixation strategy, whether they received a nail, whether they received a plate or a revision total knee replacement, and then they were reviewed for differences in postoperative systemic and surgical complications. And this figure just kind of shows intramedullary nailing. So this would be a fracture treated with a nail, as you can see, is passed below the tibial component of the total knee, safely below to transverse across the fracture. And significance for this study was defined as a p-value less than or equal to 0.5. So there were 57 periprosthetic tibia fractures included. 5 fractures were treated with revision total knee, and 100% of those that were treated with a revision had tibial component loosening. Nailing included both intramedullary nailing, which was shown previously, as well as tibio-talocalcaneal nails, which is more distal. And 11 fractures were treated with nailing. And 41 fractures were treated with plating, which was the most common fixation method. And this included plating with 1 plate or plating with 2 or more plates as well. Plating with a single plate was more common than 2 or more. So the average age for the entire cohort was 66 plus or minus 12 years. 70% of the fractures were in female patients, and 75% of the fractures were in white patients. The average BMI for the entire cohort was 35 plus or minus 10. However, there were no significant differences in age, gender, race, or BMI between the 3 groups. So within this cohort, these fractures tended to be more common in patients with an increased BMI, as well as female patients, as well as white patients. There were no significant differences in systemic complications after surgery, including myocardial infarction, DVT, and sepsis when compared between the 3 groups. There were also no significant differences in reoperation for bone healing, reoperation for infection, implant removal, or amputation. However, there was a significant difference in unplanned reoperations and fractures treated with a revision total knee, a nail, or a plate. As you can see in this chart, there were overall 0 reoperations within the nailing group when compared to that of the revision total knee and then the plating group as well. And the only significance was in this unplanned reoperations row. So in conclusion, periprosthetic tibia fractures are complex injuries that are likely to increase as total knee becomes more common in the general population, as well as the increasing age of our population. But there's limited evidence available to guide treatment as they are relatively uncommon but likely to increase. So the stability of the tibial component of the total knee replacement is of utmost importance to assess initially, as this study demonstrated that 100% of the fractures treated with a loose tibial component received a revision of their total knee. So determining this could guide operative planning. It is also important to determine what type of tibial component the patient has in the presence of their fracture, because longer tibial components, a stem that goes further down the tibia, cannot be nailed. So determining what type of implants the patient has initially will also guide operative planning. So nailing is an option when treating a type 3 fracture, so that one distal to the total knee tibial component, in the presence of a stable standard stem, because longer stems are not possible to be treated with an intramedullary nail. And historically, these have been treated with plating, as surgical options are not the same as they used to be anymore. 66% of the fractures in the plating group were type 3 fractures, while as 100% of the fractures in the nailing group were type 3 fractures. This study displayed that there were 0 reoperations within the nailing cohort. So when possible, nails should be considered as a method of definitive fixation when appropriate. Our hope is that this data can contribute to the available evidence, which can be used to minimize postoperative complications, because fractures in the presence of a total knee, they often do poorly, especially in older patients. So we should be doing anything we can to minimize these complications. And to our knowledge, this will be the largest series reported in literature that describes periprosthetic tibia fractures. And more studies are needed in the future, as this study is not without its limitations, as it is a retrospective study with still a relatively small sample size, even though it might be one of the larger ones reported. There is a need for future prospective studies across multiple centers. Thank you.
Thank you. Great job. We enjoyed it. So I have 2 questions. I have one from the chat and I have one as well, and they're both kind of nail mediated. So could you expand on what impact the fracture pattern has on the ability to technically use an IMN?
So IMNs are often reserved for type 3 fractures. So I'll go back to this slide. So a Felix type 2 periprosthetic tibia fracture, and the fracture is adjacent to the stem, IMN is often placed in the midline down through the diaphysis of the long bone. So fractures to either side of the tibial component would not be possible. And they also provide their stability distal to the tibial component. So if it was fractured superior to where it starts here or adjacent to the stem, stability could not be accomplished through using a nail. So it's often reserved for type 3 fractures that are distal, in which you can advance the nail through the diaphysis of the long bone and transverse the fracture to provide stability.
Great, thank you. And then why are the treatment options different now when we're talking about nails? Is it because these fractures are becoming more common, or the previous research has shown that nails indicated that they're more effective, or why do you think that?
Yeah, so new techniques have been described, such as a study published in 2014 by Haller, which outlined an approach that is more distal to the technique that is used for nailing a tibia that has a native joint. So the techniques have been advanced as compared to the past, when plating was the most common, and still is the most common, but we're hoping this can contribute to the evidence. And the intramedullary devices, so the actual nail, they're actually different today in terms of how much bend they have on it. Such as here is this proximal bend allows it to be safely passed inferior to the distal portion of the tibial component without getting into the stability of the knee replacement. So the bend is actually what has changed as well to allow them to be safely passed and preserve the patient's total knee. And plates are often associated with some soft tissue injuries, so nails might preserve the patient's soft tissue, so maybe less risk for infection as well.